Start the critical care station for MRCS Part B. So the first station is burn and ARDS, burns and acute respiratory distress syndrome. So the scenario is the burn victim burn in closed area. Okay, before entering the station, there is a diagram of indicating affected area. You need to calculate the surface area. So in the critical care station, before entering into the station or the before entering into the cubicle, you will be given 1 minute to read the scenario, and then you will enter the cubicle and answer the questions of the examiner, and it have 9 minutes. Okay, so in the burn station, most oftenly they give you the diagrams of the body regions which are affected by the burns, and you need to calculate the surface area. So how we will calculate the surface area of the burn? We will calculate according to Wallace rule of nines or Lund and Browder chart. Okay, Wallace rule of 9 is used to calculate the burn surface area in adults, while the Lund and Browder chart is used for peds group or child. Okay, so management of the burn patient will be according to ATLS protocol by following the A, B, C, D, and E. So first, call for help. Okay, then we will assess the airway and manage accordingly. So we will be looking for sign of airway burns and inhalational injury. Okay, so inhalational injury will be suspected when there is facial burns, burnt nasal hair, cough, sooty sputum, and voice change. So when these features are present, so we have to suspect the inhalational injury. And inhalational injury and airway burns can cause airway edema. Okay, so always give oxygen to the burn patient. Consider intubation if there is airway edema. It is called prophylaxis intubation. Then we will assess the breathing and ventilation. Ensure that adequate ventilation can be achieved, as tracheal or pulmonary burns can impair effective gas exchange. Also, full thickness chest burns, which is called a scar, which is circumferential full thickness burns. It can impede chest expansion. So always ensure these findings. Okay, that these are corrected. Then after that, the circulation, which is the main component in the burn management. Okay, so two large bore cannulae and fluid resuscitation. Okay, any patient with the greater than 15% total burn surface area, and any child with more than 10% total burn surface area. For circulation or for fluid resuscitation, we will be using Parkland formula, and the fluid which will be used is the crystallite only, for example, Hartmann solution or Ringer lactate. Total fluid requirement in 24 hours can be calculated by this formula: 2 ml multiplied by total burn surface area in percentage and body weight in kilogram. The calculated amount of the fluid: 50% of the fluid can be given in the first 8 hours. Okay, and the other 50% will be given in next 16 hours. Okay, resuscitation endpoint will be when the urine output of 0.5 to 1 ml per kg per hours in adults. Okay, so if this is achieved, okay, then it will be endpoint of the resuscitation. Okay, points to be noted: starting point of fluid resuscitation is the time of injury, and deduct fluids which are already given. Okay, deduct fluids which are already given. And for monitoring of the response to fluid resuscitation, it can be calculated or it can be detected by passing the urinary catheter or the central venous line. Okay. Okay, so this question, why not to give collide and burn? Because of the increased capillary permeability occurring during the first 24 hours, collide will pass to the extracellular, extravascular space, and it exerts an oncotic effect and cause a paradoxical augmentation of the third space, interstitial space. Okay, so it is the reason why we are not giving the collides in the first 24 hour of the burn. Okay, how do you assess the adequacy of the fluid therapy? Okay, so we can use the clinical parameters. Okay, clinical measures of the cardiac index like peripheral warmth, capillary refill time, and urinary output. Then we can use the central venous pressure and its response to fluid challenge. Core temperature, for example, rectal temperature, and hematocrit, which determines the plasma volume and the red cell mass. This is unreliable if there has been a recent transfusion or hemolysis. What are you afraid of complication of burns? So this question, the complication of burns are burns shock, which is basically the hypovolemic shock due to plasma loss following loss of skin cover, which leads to hypotension, tachycardia, increased systemic vascular resistance, and a fall in the cardiac output. Then the second complication, it can lead to sepsis, it can lead to acute respiratory distress syndrome, renal failure due to myoglobinuria, constricting circumferential burns, causing the ischemia in the limbs, ventilator problem in chest, and the circumferential burns requires the urgent sclerotomy. Okay, then the burn can lead to electrolyte disturbance like hypo or hypernatremia, hyperkalemia, and hypocalcemia. It can lead to coagulopathy due to disseminated intravascular coagulation and hypothermia, and it can also lead to hemolysis leading to hemoglobinuria and anemia. Okay, so these are the complications of the burns. How to tell how to tell if he has superficial or deep burns? Okay, so in the superficial burn, the skin is red or white in color, blistering will be present, and there will be sensate skin. It means the superficial burns are painful, while the full thickness burns are white, has white skin which is leathery in appearance, and it is desensate, which means it is painless. Okay, so the full thickness burns are painless. Now the other questions. Okay, so now we will move on to the acute respiratory distress syndrome. First, the definition. Okay, okay. So this is the X-ray which is shown, and the question is what you see in the X-ray. So this in this X-ray there are, you can see there are bilateral pulmonary infiltrates. Okay, and bilateral pulmonary infiltrate is a characteristic features, radiological feature of the ARDS, acute respiratory distress syndrome. Okay, so in this X-ray there are bilateral pulmonary infiltrates. Now, how we will define the ARDS? It is the acute diffuse inflammatory form of lung injury. Okay, acute respiratory failure which is characterized by hypoxemia. Okay, decreased lung compliance, diffuse pulmonary infiltrates on chest X-ray, normal peripheral pulmonary arterial wedge pressure less than 18 millimeter of mercury, which show that it is non-cardiac, not cardiac, and the partial pressure of oxygen to the fraction of the inspired air. This ratio will be less than 26.6 kilopascal. Okay, so this is definition. Now, what is the ratio of the arterial partial pressure of oxygen by the fraction of the inspired oxygen? Okay, so this ratio is also called Kerrico index, and it is a comparison between the oxygen level in the blood and the oxygen concentration that is breathed. This helps to determine the degree of any problems with how the lungs transfer oxygen to the blood. Okay, so this is about this ratio, Kerrico index. Then the pathophysiology of the ARDS. There are two phases which are present in the acute lung injury, or you can say acute respiratory distress syndrome. An acute phase and a late reparative phase. Okay, in the acute phase, there is widespread destruction of the capillary endothelium, which causes the extravasation of protein rich fluid and interstitial edema. Then, migration of neutrophils occurs in the capillaries and the air spaces, which causes the extensive release of cytokines. The alveolar basement membrane is also damaged because of the cytokines, and fluid seeps into the air spaces, stiffening the lungs and causing ventilation perfusion mismatch. Then the late reparative phase is characterized by the fibroproliferation and organization of the lung tissue. Okay, and if the resolution does not occur, there is disorder collagen deposition which occurs leading to extensive lung scarring. Okay, so in this image, the pathophysiology of the ARDS is shown. So the first, there is injured and swollen endothelial cells. Then the it is followed by the neutrophil migration into the air spaces. Then the neutrophil damage the air spaces and endothelium, vascular capillary endothelium, through which leading to the edema. Okay, and this edematous fluid is also shifted into the air spaces. Okay, the neutrophil also comes to the air spaces and cause and lead to the cytokine release. Okay, and these are all the stages of the acute phase of the ARDS. Then in the later reparative phase, there is fibroproliferation. Okay, due to fibroblast which secrete the frocollagen and the collagen, which causes the stiffening of the lungs and the alveoli, and there is if the resolution does not occur, then there is extensive lung scarring. Okay, so what are the causes or condition associated with the development of the ARDS? Infection can lead to ARDS like sepsis, diffuse pulmonary infection like viral mycoplasma and pneumocystis pneumonia, and miliary tuberculosis. Gastric aspiration can lead to ARDS. Then there are some physical or traumatic causes like mechanical trauma, including head injuries, pulmonary contusions, near drowning, fractures with fat embolism, burns, and ionizing radiation. Then the cause is due to hypersensitivity reaction. They are due to organic solvents and some drugs. Then chemical injury like heroin or methadone overdose, anti-salicylic acid, barbiturate overdose, and parapet. Inhaled irritants include oxygen toxicity, smoke, and irritant gases and chemicals. Then cardiopulmonary bypass can also lead to ARDS. Pancreatitis can lead to ARDS. Hematological condition like transfusion associated lung injury and DIC, it can lead to ARDS, and uremia can also lead to ARDS. So these are the causes of the ARDS due to infection, trauma, hypersensitivity reaction, chemical injury, inhaled irritants, cardiopulmonary bypass, pancreatitis, hematological conditions, and uremia. Okay. What is Berlin criteria? Okay, so the new Berlin definition of ARDS characterize it as being mild, moderate, or severe, and the Berlin criteria is based on the Carico index, okay, which is the ratio of the partial pressure of arterial oxygen with the by the fraction of the inspired air. Okay, so if the Carico index is 200 to 300, then this is mild ARDS and 27% motility. If the Carico index is 100 to 200, then it is moderate ARDS and the mortality rate is 32%. While less than 100 Carico index is severe ARDS and the mortality rate is 45%. Okay, so this is the Berlin criteria of the ARDS. Now, how we will manage the ARDS? So we will manage basically in the ARDS management. Basically, we will manage the ventilation because there is ventilation perfusion mismatch. So we have to manage the ventilation, and we will give the steroids, fluids, and nutritions. Okay, so first we will admit the patient to the ITU, give supportive therapy, and treat the underlying cause. We will give the respiratory support by the positive and expiratory pressure of 5 to 15 centimeter of water to prevent premature alveolar closure. Although PEEP helps with oxygenation, it does so at the expense of cardiac output. Then respiratory support can be achieved by prone position. This has been found to significantly improve the oxygenation up to 65%. Then steroids can be given. Low dose steroids are associated with improved mortality and morbidity outcomes. Then how we will manage the sepsis? First, we will identify organisms and then treat accordingly. If clinically septic but no organism culture, then use empirical antibiotic, broad spectrum, but avoid nephrotoxic antibiotics. Hemodynamic management, how we will manage the hemodynamic status of the patient. So fluid should be replaced but with the care not to overload. Assessment may be made by measuring blood pressure and urine output. Finer assessment may be necessary using a Swan-Ganz catheter to measure the pulmonary capillary wedge pressure. If there is evidence of circulatory failure despite adequate hydration, such as fall in cardiac or urine output, then consider low-dose dopamine as a renal arterial dilator and do butamine for its positive inotropic action. If there is fluid overload, consider furosemide 40 to 120 mg per 24 hours IV. Okay, so this is the hemodynamic management. We will replace the fluid, but we should care about the overload status. Okay, then the other supportive care like nutritional support, venous thromboembolism prevention, and gastric ulcer. Nutritional support, enteral feeding is much better than the parenteral feeding. Okay, so we will try to feed the patient by the enteral routes like oral feed or the nasogastric nasojejunal feed. Venous thromboembolism prevention can be done by giving the low molecular weight heparin, while the gastric ulcer prevention with prophylactic medication like proton pump inhibitors. Okay, what are the long-term sequelae of the ARDS, acute respiratory distress syndrome? It can lead to impaired gas exchange with refractory hypoxemia due to ventilation perfusion mismatch and physiological shunting. It can lead to decreased lung compliance because it's stiff and lead to stiff and poorly and non-aerating region of the lungs. Pulmonary hypertension can also occur as a result of ARDS. Okay, so this is date uh, Wallace rule of 9. So according to Wallace rule of 9, The head is 9%, 4.5% interior and 4.5% posterior. Okay, the whole upper limb is 9%, one on each side. Okay, the interior is 4.5, the posterior is 4.5. The interior upper chest is 9%, while the posterior upper chest is 9%. So it means the whole chest is 18%. The abdomen is the lower abdomen, or you can say the lower interior trunk is 9%, while the lower posterior trunk is 9%. Okay, so the lower trunk total is 18%, 9% interior and 9% posterior. The perineal region or the genital region is 1%. The lower limb as a whole is 18%, 9% interior and 9% posterior. Okay, so this is Wallace rule of 9. We have already discussed these questions. Now we will move on to the another station, which is the head injury and extradural hematoma. The scenario is road traffic accident patient presented with GCS of 15. He has two episodes of vomiting, amnesic events, and later on the GCS become 8. Plus there is scalp laceration. Okay, so in this scenario you can see that the GCS, first the GCS is normal, which is 15%. Okay, and then the GCS drop to 8%. Okay, so this condition in which there initially there is improvement in the patient's condition, then there is deterioration of the consciousness or the GCS score. This is called lucid interval, and the lucid interval occurs in extradural hematoma, or you can say the epidural hematoma. Okay, and the CT features. So what will be the CT findings of the, in this image you can see this is the CT image which shows the extradural hematoma, and the extradural hematoma will be biconvex in shape. Okay, and it is hyperdense. Okay, so this is the biconvex hyperdense lesion, and there will be midline shift. Okay, so there is midline shift and with the compression on the ventricles. Okay, the compression on the ventricles. Okay, so these are the three features of the extradural hematoma. Okay, so the first feature, the extradural hematoma, biconvex hyperdense lesion, midline shift and compression on the ventricle. So these are the three features, findings or features of the extradural hematoma. Okay, when to consider CT brain for trauma. Okay, so there is high risk criteria for CT brain for head injury and medium risk criteria. When we will be undergoing the CT brain in the trauma patient. So if the GCS is less than 15 at 2 hours post injury, this is one criteria, or the suspected open or depressed skull fracture, or any sign of basilar skull fracture. Okay, if there are any sign of basilar skull fracture, then we will have to do the CT brain. What are the sign of basilar skull fracture? This is the hemotympanum. Okay, hemotympanum is the blood from the air. Okay, raccoon eyes, which are the periorbital um, depigmentation, or you can say the periorbital hematoma. Battle sign, which is basically the blood collected in the mastoid region. The CSF autorhinuria. Okay, so these are the sign of basilar skull fracture. The high risk criteria also include two or more than two episodes of vomiting. Okay, so if there are two or more than two episodes of vomiting, then this is high criteria high risk criteria for CT brain for trauma. Age 65 or more than 65, or any head injury in anticoagulant patient. These are the high risk criteria. While medium risk criteria include the retrograde amnesia to the event of 30 or more than 30 minutes, and dangerous mechanism like the pedestrians struck by motor vehicle, occupant ejected from motor vehicle, fall from more than 3 feet or more than 5 stairs. So these are the medium risk criteria. Normal value for ICP, it is 7 to 15 millimeter of mercury when the patient is supine, and minus 10 when he or she is standing. Ways to measure. What are the ways to measure the intracranial pressure? They are intraventricular catheter, which is the gold standard method to measure the ICP, intracranial pressure. But it is the most invasive method. There is high infection rate. It may be difficult to insert, and there is simultaneous CSF drainage and ICP monitoring, which is not possible. The second method is intraparenchymal probe. Okay, intraparenchymal probe. The main advantage of it is the low infection rate, but there are some limitation, like it measures local pressure and drift of zero over time. Subarachnoid probe, low infection rate and no brain penetration. These are the advantage of the subarachnoid probe. While the disadvantages include limited accuracy, high failure rate, and periodic flushing is necessary. Epidural probe advantages include low infection rate, easy to insert, and no penetration of dura, while the disadvantage include limited accuracy and relatively delicate. Lumbar CSF pressure advantage is that it is extracranial procedure, while the disadvantage it is the inaccurate reflection of the ICP and may be dangerous when brain edema is present. Then the tympanic membrane displacement and transcranial Doppler. These are the most non-invasive method to measure the intracranial pressure: tympanic membrane displacement and transcranial Doppler, but there is limited precision of both procedure. What is the danger of the lumbar puncture in increased ICP? Okay, so the due to increased ICP, when the lumbar puncture is done in the increased ICP, there is a risk of herniation and coning. Okay, what are the risks and benefits from measuring ICP? The benefits are that it helps to determine the intracranial pressure and consequently cerebral perfusion pressure. But the risks are bleeding and infection from the intraventricular catheter. This is bleeding and infection, while from the lumbar puncture, there can be herniation and coning. What is the Cushing reflex? This question, what is Cushing reflex? It is the physiological nervous system response which is mixed vagal and sympathetic stimulation due to an elevated ICP that results in Cushing triad. And Cushing triad includes the hypertension, the bradycardia, and irregular breathing. Okay, so this is the Cushing triad: hypertension, bradycardia, and irregular breathing. Then the pathophysiology of the increased ICP. Okay, so the pathophysiology of the increased ICP follows the Monro-Kelly-Dectroin hypothesis, according to which the skull is fixed boxed containing three components: brain 80%, blood 10%, and CSF 10%. ICP to by volume relationship is governed by these three components. If there is increase in volume in one component, it may result in compensatory decrease in the volume of another component. In order to prevent rise in ICP, compensatory mechanism. Okay, so however, when once the ICP has reached to around 25 millimeter of mercury, then the small increase in brain volume can lead to marked elevation in the ICP. This is due to failure of intracranial compliance, failure of compensation, leading to brain herniation. What is lucid interval? We have already discussed it. A temporary improvement in a patient condition after traumatic brain injury, after which the condition deteriorates with the rapid decline of the consciousness. During this period, blood accumulates. Okay, so during the deterioration phase, the blood accumulates in the extradural space, leading to increase in ICP, leading to cerebral ischemia. This is the formula through which we can calculate the cerebral perfusion pressure. It is equal to mean arterial pressure minus intracranial pressure. And mean arterial pressure is equal to diastolic pressure plus one third of the pulse pressure, which is systolic minus diastolic pressure. Mean arterial autoregulation range is between 50 to 150 millimeter of mercury to maintain a constant cerebral blood flow in cases of traumatic brain injury. This will be disruption of the mean arterial pressure autoregulation, which can lead to cerebral ischemia. Okay, if if the patient has chest trauma, how can it affect the cerebral perfusion pressure? Okay, so the first one is reason the mean arterial pressure will decrease. Okay, which will decrease the cerebral perfusion pressure. Mean arterial pressure will be decreased due to injury of the great vessels and hypovolemia, which decreases the mean arterial pressure and decreases the cerebral perfusion pressure. The second reason is trauma will result in pneumothorax, which will lead to hypoxia, which lead to decreased cerebral perfusion pressure. The third cause is trauma head injury, which can cause shallow breathing due to Cushing triad, causing hypoxia, causing vasodilation, and subsequent reduction of the mean arterial pressure, and eventually decreases the cerebral perfusion pressure. Clinical picture of the increased ICP. It includes the headache, nausea and vomiting, papilledema, fall in GCS due to pressure symptoms of hematoma and ischemia, loss of auto-regulation of the mean arterial pressure. Dilated pupil can be seen in the increased ICP due to oculomotor nerve palsy, defect in lateral gaze due to abducens nerve palsy, and Cushing triad, not to be confused with the Cushing reflex. The Cushing triad include the increase in blood pressure, hypertension, bradycardia, and irregular respiratory breathing. How we will manage the patient? By following the ABC protocol, and we will intubate the patient. Why the intubation? So these are the indications of the for the intubation. The GCS of 8 or less than 8, risk of raised ICP due to agitation, i.e., sedation required, inability to control and protect the airway, or loss of protective laryngeal reflexes, a fall of 2 or more points in the motor components of the GCS. It is also one of the indication of the for the intubation. In order to optimize oxygen and ventilation, seizures, bleeding into mouth and airway, bilateral fracture mandible, and severe facial injury, these are the indications for the intubation. Management of the raised ICP. First we will do medical management, and then we will if there is no response to medical management, then we will do the surgical management. So in this medical management, we will manage the patient to improve the venous drainage from the brain. So venous drainage from the brain can be improved by the elevation of the head of the bed to 30-degree, good neck alignment, head in the neutral position, ensuring ties holding the endotracheal tube in place do not compress the neck veins. Alternatively, tape the tube using trouser legs. Where possible, immobilize the patient's cervical spine with sandbags and tape rather than restrictive neck collars. Then, medical management to reduce the cerebral edema by using the mannitol, which is the osmotic diuretics, in the dose of 0.5 to 1 gram per kg. Okay, use furosemide, which is a loop diuretic, in the dose of 0.5 to 1 milligram per kg, and maintain serum sodium in the range of 140 to 145 millimole per liter. Medical management to reduce the cerebral metabolic rate for oxygen. It can be achieved by the close temperature regulation, avoid hypothermia but do not actively induce hypothermia. Avoid hyperthermia, sorry. We should avoid the hyperthermia but we will not actively induce hypothermia. Use of sedation and anesthetic drugs. Ensure that the patient is appropriately sedated and has received adequate analgesia. If the patient has a witness seizure, loading with the anticonvulsant, usually phenytoin 18 mg per kg, should be considered. In case of intractable raised ICP, a thiopentone infusion can be used to reduce the cerebral metabolic rate to a basal level. This is identified on EEG monitoring as burst suppression. Medical management to reduce the intracranial blood volume by hyperventilation, which can be used to reduce the partial pressure of arterial carbon dioxide as a temporary measure, but cerebral ischemia may result if this is prolonged. The final resort, if the ICP remains raised, is to perform decompressive craniectomy, which is the surgical option. Okay. So the surgical option include decompression, which is done by the first we will remove the hematoma, then decompressive craniectomy. Okay, decompressive craniectomy, and the third one is the drainage by catheter. Okay, so this is how we will manage the extradural hematoma or the increase in ICP. Then the third station is of the subdural hematoma. Okay, subdural hematoma. The scenario for the subdural hematoma: 18-year-old woman who fell down in the emergency department, the eyes open to pain, make incomprehensible sound, and withdraws to painful stimulus. Okay, so these are the GCS score. Okay, so how the GCS score is the Glasgow Coma scale. Okay, what is GCS score and what is her GCS score? Okay, so this is the 80-year-old woman. So how we will calculate the GCS and what is GCS score? So the Glasgow Coma Scale is a neurological scale which aims to give a reliable and objective way of recording the conscious state of a person for initial as well as subsequent assessment. So in this scenario, how to calculate the GCS score? So GCS score is total of 15 score. Okay, GCS has 15 points and it includes the three components: EVM, eye opening, verbal response, and motor response. Eye response has total of 4 points, verbal response has total of 5 points, and the motor component has total of 6 points. Total points for the GCS is 15. Okay, the minimum score of the GCS can be 3. okay, and the maximum score is 15. GCS cannot be 0. Okay, so now we will calculate the GCS score of this lady, 80-year-old woman with subdural hematoma. So the eyes open to pain. Okay, so the eyes open to pain has 2 points. Okay, so the eyes open to pain has 2 points. So the eye opening has 2 points of this lady, while the verbal response, she makes incomprehensible sounds. So the sounds point is 2. While the motor component, she withdraws to painful stimuli, which has point of 4. Okay. So the total score of this lady GCS, total GCS is 8. Okay, out of 15. So the GCS score has three main components: eye opening, verbal response, and motor response, EVM. Eye opening has total of 4 points, verbal response has total of 5 points, and the motor component has 6 points. The eye opening, if there is spontaneous eye opening, then it has 4 points. If the eye opening is to speech, then 3 points. If the eye opening is to pain stimulus, then it has 2 points. And when there is no eye opening, okay, then the score is 1. Verbal response, the if the person is oriented to time, place, and person, then the verbal response is maximum, which is 5. If the patient is confused, then the point is 5. If they make words or they just utter words, then the point will be 4. Okay, sorry, 3. And if they make the sounds, then the point will be 2, and no verbal response will be 1. The motor response will be maximum if the patient obeys commands, which will be 6. If the patient localizes to pain, okay, then the GCS will be, the motor response will be 5. If they withdraws from pain, then the score will be 3. Okay, sorry, 4. And if there is abnormal flexion to pain, then the score will be 3. And if they extend to pain, then the score will be 2, and no motor response will be 1. So this is about the GCS score. Now this CT scan is show. So what are the positive findings in this CT brain? So you can see this is the hyperdense lesion, which is crescent shape or lens shape. There is midline shift, and there is compression on the ventricles. Okay, so these three features: crescent shape lesions, midline shift, and compression on the ventricle, this shows the subdural hemorrhage, and in this case the right subdural hemorrhage. What does loss of gray white matter suggest? Many studies have shown that injury to gray matter, area of the brain that contains the nerve cell bodies, can cause long-lasting cognitive disability. We have already discussed the GCS score. Management of acute subdural hematoma. Acute subdural hematoma. For acute subdural hematoma, the urgent surgical evacuation for hematoma will require. And acute subdural hematoma with or without coma with neurological deterioration, sign of increased intracranial pressure since time of injury with potential for recovery. In this case, there will be urgent surgical evacuation of the hematoma. Then, if the clot thickness is 10 mm or midline shift is more than 5 mm on initial brain CT, regardless of GCS, we will go for urgent surgical evacuation. Non-surgical managed patients should be nursed in ICU with ICP monitoring and serial head CT scan. Next CT scan at 6 to 8 hours. If there are signs of neurological deterioration or persistently increased ICP of more than 20 millimeter of mercury, then urgent surgical evacuation within 2 to 4 hours of the deterioration will be required. Tracheostomy tube advantage. So, what are the advantages of the tracheostomy tube? The first is easier cleaning of the mouth and face, less likely to aspirate, less dead space, better tolerated on the long term, more comfort, no gagging, doesn't need sedation, may help weaning the patient from the ventilator, and may allow swallowing and the ability to eat and drink. So, these are the advantages of the tracheostomy tube. Then, the next question is polytrauma. RTA patient and the patient is hemodynamically unstable. So, how we will manage the patient? So, the management will be according to ATLS protocol. Primary survey include the airway, breathing, circulation. Okay, airway and circulation, cervical spine control assessment. How we will assess the airway and cervical spine? So we will speak to the patient. If they can speak, then the airway is secure. If cannot speak, oxygen 12 to 15 liter to reach oxygen saturation, partial pressure of oxygen or oxygen saturation to 95%. If the patient cannot speak, then we have to look, feel and listen. Look in the mouth for foreign body or in the face for maxillofacial injury. Feel the breath on your cheek. Listen to abnormal breath sounds like stridor or hoarseness. How we will manage the airway? First, call for help. Remove any foreign body in the mouth, chin lift or jaw thrust maneuver, oro or nasopharyngeal airway, endotracheal intubation, surgical airway include cricothyroidotomy and tracheostomy, which is done in between the second to fifth tracheal ring. Immobilize the cervical spine by triple fixation, which include the hot collar, sandbag, and the tape. Breathing can be assessed by the inspection. Inspect for any obvious ear, chest injury, open wounds, flail segment, count respiratory rate, symmetrical chest wall movement, and use of accessory muscles. Palpation. Palpate for central trachea and surgical emphysema. Percussion and auscultation for obvious hemo or pneumothorax. Presence of any added sounds like stridors and wheeze. Management. How we will manage the breathing? By giving the high flow oxygen through non-rebreather mask, needle thoracostomy or chest tube, occlusive dressing for open pneumothorax. Comment on this x-ray. So this x-ray is shown. In this x-ray you can see the rib has been fractured. Okay, there is the surgical emphysema is present. Okay, the surgical emphysema is present, and there is the shifting of mediastinum. Okay, the shifting of the mediastinum to the right side. So this is the tension pneumothorax of the left side. Okay, tension pneumothorax of the left side. How will you manage this patient? So for the pneumotension pneumothorax, first in the urgent treatment is needle thoracostomy in the fourth or fifth intercostal space interior to the mid axillary line, and then the definitive management is chest tube insertion in the fifth intercostal space. Now the C is circulation. Okay, so how we will assess the circulation? By looking at the pulse rate and the character pulse rate and character, the blood pressure, the level of consciousness, warm extremity and skin perfusion and capillary refill time. Okay, then we should classify the hemorrhagic shock. Okay, whether it's class 1 hemorrhagic shock, class 2, class 3, or class 4. So in the class 1 hemorrhagic shock, you must see the pulse rate, the blood pressure, respiratory rate, okay, the symptoms, the urine output. These are the must thing you must check in the to assess the class of hemorrhagic shock. So in the class 1 hemorrhage, the pulse rate is less than 100, while in the class 2 shock it is more than 100. In the class 3 it is more than 120, and in the class 4 it is more than 140. While the blood pressure is normal in the class 1 and the class 2 shock, but it is decreased in the class 3 and class 4 shock. Now, how we will differentiate the class 3 and class 4 shock? So, based on the pulse rate, which is more than 120 in the class 3 shock and more than 140 in the class 4 hemorrhagic shock. While the respiratory rate is 14 to 20, which is normal in the class 1 shock. In the class 2 shock it is 20 to 30 per minute, and in the class 3 it is 30 to 40 per minute, and in the class 4 shock it is more than 35. The symptoms are in the class 1 shock, it is the patient is normal, while in the class 2 the patient is will be anxious. In the class 3 they will be confused, and in the class 4 they will be lethargic. The urine output in the class 1 shock is more than 30 ml. In the class 2 shock, 20 to 30 ml of urine output. In the class 3, 5 to 15 ml, and in the class 4 shock the urine output is less than 5 ml. Okay, for the class 4 shock there is need for massive blood transfusion protocol, while in the class 3 the massive transfusion protocol is not required, but the blood transfusion is required. And in the class 2 shock there is possibility that the person may need the blood transfusion. And in the class 1 shock we will monitor the patient for any deterioration. Okay, so these are the blood loss percentages. In the class 1 shock it is less than 15% of blood loss. In the class 2 the blood loss is 15 to 30%. In the class 3 it is 30 to 40%, and in the class 4 shock it is more than 40%. Blood loss in ml, less than 750 ml in class 1 shock, 750 to 1500 in the class 2 shock, 1500 to 2000 ml in the class 3, and more than 2000 ml in the class 4 shock. Okay, so these are the classes of the hemorrhagic shock. How we will manage the circulation of the patient? First, stop any obvious source of bleeding. Place the two large bore IV cannulae. Take blood for full blood count, glucose, urine, arterial blood gases. Cross match for 4 units of blood. Commence IV fluid resuscitation with 1 liter of crystallides. Consider blood transfusion if no response to fluids. How will you monitor the response? So it can be done by the heart rate, blood pressure, capillary refill time, urine output, and mental status. Comment on this CT scan. Okay, so this CT scan shows the liver tear. Okay, there is a liver tear. Management of liver tear can be done conservatively by starting the blood transfusion, monitoring of the hemodynamic status of the patient. Then the surgical treatment include the damage control surgery by perihepatic packing, repair of the liver, and resection of the part of the liver which is damaged. Was CT a good investigation of this patient? As this patient is hemodynamically unstable, so the CT is not a good option or good investigation for this patient. First will be the investigation of choice. in the hemodynamically unstable, and FAST is focus assisted sonogram of trauma, and the four areas will be examined in the FAST scan for the free fluid. The four areas are perihepatic space, which are also called Morrison pouch or the hepatorenal recess, perisplenic space, pericardium, and pelvis. Okay, so these are the four areas which should be examined for free fluid in the perihepatic space. Now, the grades of liver. American Association for the Surgery of Trauma liver injury scale include the grade 1, grade 2, grade 3, grade 4, grade 5 and grade 6. While the World Society of Emergency Surgery, it is it is based on the AST grading system. The WSES grading system is grade 1, which is the AST grade 1 through 1 and 2. Okay, while the grade 2 of the WSES is moderate hepatic injury with the AST grade of 3. So AST grade 3, which is hemodynamically stable, is moderate hepatic injury, while the severe hepatic injury is grade 3 of WSES grading, and it include the AST grade 4 to grade 6 hemodynamically stable patient, while the grade 4 is severe hepatic injury. Okay, it is the AST grade from grade 1 through grade 6 if the patient is hemodynamically unstable. Okay, so the minor hepatic injury is AST grade 1 and grade 2 hemodynamically stable. Moderate hepatic injury is AST grade 3 hemodynamically stable. Severe hepatic injury is grade 4, grade 5, grade 6 hemodynamically stable, and severe hepatic injury, the liver injury in which the patient is hemodynamically unstable. Okay, so it is based on the hemodynamical stability and AST grading system, WSES. Okay, so these are the AST grading system of the liver injury. Grade 1 is hematoma, subcapsular hematoma less than 10% of surface area, or the capsular tear less than 1 centimeter. Grade 2 is subcapsular hematoma 10 to 50% of the surface area, or the capsular tear 1 to 3 centimeter, or the intraparenchymal hematoma of less than 10 centimeter. Grade 1 and grade 2 is minor hepatic injury, and these are the this is the grade 1 and grade 2 is grade 1 of the WSES system, WSES grading system. Okay, WSES, this is the minor hepatic, while the grade 3 is moderate hepatic injury, and it has subcapsular hematoma of more than 50%, or the capsular tear of more than 3 centimeter, and or intraparenchymal hematoma of more than 10 centimeter are expanded. The grade 3 is moderate hepatic injury based on the WSES grading system. Grade 4, grade 5 and grade 6 are severe hepatic injury. Okay, so these grading minor hepatic injury, moderate and severe, these are based on the when the patient is hemodynamically stable. Okay, so the if the patient is hemodynamically stable, then if the patient is grade 1, grade 2, grade 3, grade 4, grade 5 or grade 6, then the patient will be considered a severe hepatic injury. Okay, so it is also based on the hemodynamically stability. Grade 4 is laceration of Laceration involves the 25 to 75% of hepatic lobes or 1 to 3 coinoid segment. Grade 5 is laceration, which involves more than 75% of hepatic lobes or involves more than coinoid segments within one lobe. Grade 5 is vascular injury of juxtahepatic venous injury, retrohepatic vena cava, or central major hepatic vein. Grade 6 is hepatic avulsion. Okay, so these are the grading system. Then moving to the next station, which is the polytrauma with C-spine fracture. 26-year-old male cyclist involved in RTA with spine and chest trauma and hemorrhagic shock secondary to hemothorax. Okay, so the patient is in a hemorrhagic shock. So as the patient is in hemorrhagic shock, so we will manage the patient according to ATLS protocol. First, we will do airway and cervical spine control. Okay, then we will manage the airway. Okay, if there is any disturbance or the airway is insecure, then we will manage. Then we will assess the breathing and circulation, breathing and ventilation, and then accordingly manage the breathing and ventilation. Okay, then circulation assessment and management, we already discussed these. Classes of hemorrhage we also discussed in the previous session. Define shock. So shock is basically a state of cellular and tissue hypoxia. The state of hypoxia, cellular or tissue, due to reduced oxygen delivery and or increased oxygen consumption or inadequate oxygen utilization. Types of shocks include distributive shock, cardiogenic shock, hypovolemic shock, obstructive shock, and combined shock. Okay, distributive shock includes septic shock, systemic inflammatory response syndrome, neurogenic shock, anaphylactic shock, drug and toxin induced shock, endocrine shock. Cardiogenic shock include cardiomyopathic or arrhythmic and mechanical. Hypovolemic shock include hemorrhagic and non-hemorrhagic. Obstructive shock include pulmonary, vascular, and mechanical. And the last one is combined shock. Differences between the spinal shock and neurogenic shock. So first the definition. Spinal shock is the immediate temporary loss of total power, sensation, and reflexes below the level of injury, while the neurogenic shock is sudden loss of sympathetic nervous system signals above T6 vertebral level. Blood pressure is decreased in both shock, spinal and neurogenic. So hypotension is can be seen in spinal as well as neurogenic shock. Bradycardia is also present in both shock, spinal and neurogenic. Bulbocavernous reflex is present in some cases and absent in some cases in the neurogenic shock, but it is always absent in the spinal shock. Motor response or motor system, there is placid paralysis in the spinal shock, while in the neurogenic shock it is variable. Time, it spinal shock take weeks to months, while neurogenic shock take hours to days. Okay, mechanism involved in the spinal shock is the peripheral neurons become temporarily unresponsive to the brain stimuli, while the neurogenic shock there is disruption of the autonomic pathways which lead to loss of sympathetic tone and vasodilation. Okay, so this is the differences between the spinal shock and neurogenic shock. Agents give in neurogenic shock, it include phenylephrine, which is alpha 1 alpha agonist, okay, dopamine and norepinephrine. In the ATLS protocol, after ABC we will assess for the disability. As soon as the patient's cardiopulmonary status is managed, perform a rapid focused neurological examination. This consists primarily of determining the patient's GCS score, pupillary light response, and focal neurological deficit. Then, in the exposure part of the ABCDE, we will use the log roll maneuver to evaluate the patient's spine and any posterior chest injuries. In the log roll maneuver, there will be four persons. The first person will be on the head side, which will stabilize the head and the cervical spine, while the two-person on the other side of the patient will move the patient, or okay, they will move the patient or turn the patient on the same side where they stand. And the fourth person, this one will examine the back and will remove the spine board. Okay, identify the problems in the CT scan. So you can see this is the fracture of the C3 cervical spine with displacement and cord compression. Then what are the spinal cord syndrome? These include the central cord syndrome, anterior cord syndrome, Brown Sequard syndrome, and posterior cord syndrome. So in the central cord syndrome, it occurs after a hyperextension injury in a patient with pre-existing cervical canal stenosis, and it is characterized by the greater loss of the motor strength in the upper extremity than the lower extremity. Okay, and the prognosis of this central cord injury is better than other incomplete injury. Then the interior cord syndrome is characterized by the paraplegia and bilateral loss of pain and temperature sensation. However, the sensation from the intact dorsal column, position, vibration, and deep pressure sense is preserved. It results from the injury to the motor and sensory pathways in the interior part of the cord, mostly after cord ischemia. This syndrome has the poorest prognosis in recovery of the incomplete injury. Then the Brown Sequard syndrome, it results from the hemisection of the cord. Hemisection of the cord usually due to penetrating trauma, and it is characterized by the ipsilateral motor loss due to corticospinal tract lesion, damage and loss of position sense. Okay, so there is ipsilateral motor and position sense loss associated with the contralateral loss of pain and temperature sensation due to spinothalamic tract. Then the posterior cord syndrome, patient come with the loss of position sense, vibration sense, and ataxia. Clinical assessment of spinal cord tract. So the corticospinal tract is present in the interior and lateral segments of the cord. It controls motor power on the same side of the body, and it is tested by the involuntary muscle contraction or involuntary response to painful stimuli. Spinothalamic tract is present in the anterior-lateral aspect of the cord. It transmits pain and temperature sensation from the opposite side of the body, and it can be checked by the pinprick sensation. Dorsal column tracts, it lies in the posteromedial aspect of the cord. It carries position sense, which is called proprioception, vibration sense, and some light touch sensation from the same side of the body. It is tested by a position sense in the toes and fingers or vibration sense using a tuning fork. Then the next station is polytrauma with pelvic fracture. Okay, the scenario is a 28-year-old motorcyclist has fractured his femur and tibia, treated along with ecchymosis in the flanks, tenderness and pain in the lower abdomen with blood at the urethral meatus. The patient is pale, hypotensive, and tachycardia. Okay, so if the patient is hypotensive and tachycardia, you you must know that this patient is in the hemorrhagic shock. Okay, so what other injury would you suspect and how will you manage the condition? Okay, as the patient has fractured femur and tibia, but the other characteristic or the other clinical picture which is present in this patient is tenderness in the lower abdomen and blood at the meatus, which can show the ruptured bladder or urethra. Renal injury because the ecchymosis in the flanks and the vascular injury. Since the patient has an RTI, I will follow the ATLS protocol with A, B, C, D, and E approach. What is the first thing you will do? Okay, so first thing is C, A, B, C, D, E. So the first thing is cervical spine control. Immobilize the C spine with the triple fixation. Breathing is fine. What will you do in circulation? So for the circulation, first assess the pulse rate and character, blood pressure, capillary refill time, pallor and peripheral temperature, then the ECG. Okay, then place two large bore IV cannulae into the antecubital fossa, taking blood for the full blood count, the LFTs, the glucose, ABGs, lactate, coagulation, and cross match for at least 4 unit of bloods. Okay, then start fluid resuscitation with the 1 liter of the warm crystallites. Okay, and move on to looking for any obvious source of bleeding in the chest, abdomen, pelvis, long bones or floor, the 5 area discussed in ATLS and other fast scan. If there was any question of pelvic injury, I would put on a pelvic binder and it would be appropriate to ask for a trauma series. Trauma series consists of cervical spine X-ray, chest X-ray and abdominopelvic X-ray. Describe the finding of this X-ray pelvis. Okay, so you can see this positive finding in the red arrow. In the red arrow, you can see the positive finding of this X-ray. Okay, red line shows the increased pubic diastasis. Okay, so the positive findings in this X-ray is increased pubic diastasis distance along with sacroiliac joint disruption. Okay, what are the types of pelvic fractures? There are four patterns that can be seen in the pelvic fracture. It includes the AP, entropy, posterior compression, lateral compression, vertical shear, and complex pattern. What type of shock in this patient? Hypovolemic shock. Given that the patient has hypovolemic shock, what percent of blood loss would you suspect? Due to a pelvic, femoral, and tibia fractures, grade 4 shocks, that is more than 40% of the blood loss as they have decreased BP, but they have a pulse rate of more than 140 beats per minute. What do you expect the pulse pressure to be in this patient? Narrow pulse pressure because the hypovolemia decreases the systolic blood pressure and increases the diastolic blood pressure. How would you manage the hypovolemic shock? Okay, so the hypovolemic shock, we already discussed that in the circulation part of the ABC. First we will assess the circulation and then we will stop any obvious source of bleeding. Okay, um, place the two large bore IV cannula. Okay, and start the IV fluid resuscitation by 1 liter crystallites. Okay, and monitor the response of the patient to the fluid resuscitation. And also we must in the pelvic fracture, we must uh, place the pelvic binder. Okay, how will you monitor the response? Already discussed by heart rate, blood pressure, capillary refill time, and urine output and mental status. What does blood on the urethral meatus signify? It signifies the urethral trauma, which is in the pelvic fracture. Membranous urethra is mostly rupture. What are other urinary organ is most commonly injured in a pelvic fracture? It is urinary bladder. How will you confirm the diagnosis? Diagnosis can be confirmed by the anterograde cystourethrogram, retrograde urethrogram, and CT scan. What are the contraindication to Foley's catheterization? Contraindication to Foley's catheterization include the pelvic fracture, blood at the meatus, urethral trauma, perineal hematoma, bleeding tendency, pre-existing infection around the glands or the meatus, high riding prostate on DRE, and meatal stenosis. How will you manage and who will you involve? So, if this patient has um, ruptured urethra, then we will call for urologist, and we will do suprapubic catheterization. What other types of urinary catheters do you know? So other urinary catheters include the condom catheter, straight catheter, Cowdy tape catheter, silicone catheter, three-way catheter for continuous bladder irrigation, suprapubic catheter, and Nelaton's catheter for irrigation of clots. Would you request the whole body CT scan for this patient, and why? Okay, so the advantage is that it is used in the polytrauma patient, the whole body CT scan, to early diagnose the patient and improve the survival rates. Rule out or determine the extent of the injury and location of the disease or trauma or other medical condition. Disadvantages of the whole body CT scan include the high radiation exposure and the cost. It is not cost effective. Causes of narrow pulse pressure. In the hypovolemic shock, there is decrease in circulating blood volume, which will decrease the systolic pressure, but there is increase in systemic vascular resistance, which increases the diastolic pressure. So the net result is narrow pulse pressure. How will you manage the pelvic fracture? When there is suspected active bleeding from a pelvic fracture, apply a pelvic binder in the correct position. This should be applied pre-hospital if possible. Then IV zinc acid should be given as soon as possible. Suspected pelvic fracture from high energy trauma should be having a CT scan with IV contrast, including head, chest, abdomen, and pelvis on admission. This should include a head to toe scanogram. Active bleeding from the pelvis in patients who do not respond to resuscitation can be managed by surgical packing of the pelvis or interventional radiology with selective embolization of the active arterial bleeding vessels. External fixation should be considered for temporary mechanical stabilization when early definitive surgery cannot be performed. In displaced vertical shear fracture, traction should be considered when early definitive surgery cannot be performed. Potential injury to the bladder or urethra should be suspected and diagnosed and managed according to the management of urological trauma associated with pelvic uh, fracture, and patient should be referred to urologist. Open pelvic fractures associated with the wounds to the lower abdomen, groin, buttocks, perineum, anus, including sphincters and rectum, required urgent assessment by a consultant general or colorectal surgeon and wound debridement as per the open fracture ghost. Reconstruction of the pelvic ring should occur within 72 hours of the stabilization of the patient physiological status state if associated injuries allow. Okay, so after the initial management, surgical consult and application of the pelvic binder or wrap. If there is intraperitoneal blood, then we will go for laparotomy. If no intraperitoneal blood and there is no response to fluid, then preperitoneal packing and angiography can be considered. Okay, so this is about the pelvic injuries. Next station is crush injury or compartment syndrome with and rhabdomyolysis.